Qui répond?
This meeting is being recorded.
Who want to answer? Parents or medical team, both?
Both.
Okay, that's amazing. So both. Okay, so now I'm following up from that particular question. If we had a situation where we disagreed, then who should decide? So if we want to stop life-sustaining intensive care, but the parents don't want to, so at the end of the day, who is responsible for that decision?
Medical team.
Okay, and just in France where you practice, if you had a disagreement, how would you approach that?
Donc, quand il n'y a pas de consensus parent, médical, staff, le dernier mot revient à qui?
Doctors.
Final word to the doctors in France.
Okay,
So
that's very kind of all of you to share. And I would say that in the UK, it's very similar. I think if we had to make a decision in any baby's best interests of stopping life-sustaining intensive care, eventually, while the parents need to be counseled, the medical team is really responsible for making those decisions. The problem it creates is it creates conflict if you're kind of in the situation where you are unable to come to an amicable kind of consensus with the parents about how this should be done. Now, as part of the kind of teaching objectives, having summarized that, what I'm going to talk about with you today is why we disagree with parents, especially if they have different religious, cultural, and spiritual kind of beliefs. The second thing that we're going to talk about is how you as a team might want to approach that with different cultures. And when I say different cultures, there might be strong religious beliefs, or you might have people who have very strong cultural values, not necessarily religious beliefs, where they feel very strongly that they should be the decision makers and not the medical team. And then after that, what we will do is discuss a framework that I believe is applicable everywhere. I would say that you can use that framework to give people a really good feel of how you might approach these disagreements in those circumstances. So I'm just going to give you a little bit of a flavor. So when we talk about problems with medical intensive care, we're kind of in the situation where extreme prematurity has a huge burden. And what you can see here is I'm just giving you a flavor of survival to hospital discharge in babies at 22, 23, 24, and 25 weeks. And this is a very large cohort. I mean, this is babies from 1993 to 2015. And what you can see from our perspective is that, you know, less than 10% of babies at 22 weeks, and those are the figures that I would quote in most neonatal units in the UK, even in the UAE, survive. And that is because we stop life-sustaining intensive care. But that actually increases quite significantly as you move down to about 50% at 23 weeks. And at 25 weeks, survival, you know, is about 80%. I can say for a fact that in Southampton, where I used to work, our survival at 24, 25 weeks was actually near 90%, very high. At 23 weeks, we were about 60, 65%. But at 22 weeks, it's only 10%. So there is a huge burden of, I would say, morbidity and mortality that you would see at extremes of viability. And the reason I'm using this example is because when you look at population studies in different countries, what you're actually going to see is there is a huge difference in survival in different countries following very similar practices. So, you know, I would say that the practice in France and the practice in Sweden and the UK is very similar. But when you go and look at survival figures, say for babies at 24 weeks, so in this work, 31% of babies survive to discharge at 24 weeks of gestation in France based on the paid study. But actually, when you look at the UK, this figure is about 40%. And in Sweden, this figure is very high. It's about 70%. So survival is much higher in Sweden. So the key question that we're kind of thinking of is, why is there such a significant variation in survival amongst countries. So does the group have any thoughts?
Because they begin the resuscitation at 22 weeks. In France, we don't resuscitate the 22 weeks old babies.
Correct. But the figure that I'm looking at is actually you resuscitate at 24 weeks. And if you look at 24 weeks resuscitation, the figure of survival, both in the UK and France, is the same. But in Sweden, it's very high. So why is that? Why is there a difference at 24 weeks? Or for that matter, even at 25 weeks, what you can see is that, again, the figure in France and the UK is pretty similar, 60%. But when you go to Sweden at 25 weeks, it's 81% survival. That's really high. Any thoughts? Any thoughts? You'll all be right. You can answer. This is meant to be interactive. So I'm really keen to have your views, your thoughts.
The efficiency. The Sweden are more efficient.
Okay. Any other thoughts? If I provide you with a flavor of the culture amongst medical fraternity. So in Sweden, they follow an active management approach where they will resuscitate, as you rightly said, at 22 weeks of gestation. But more importantly, their active management approach, when it looks at counseling parents, is very proactive in saying that the survival figures are good, so we will resuscitate your baby. So if you look at the culture in Sweden and with parents, our colleagues in Sweden who are doing a fantastic job will counsel and say that actually from our perspective, we're in a situation where we have a high survival and resuscitation would be the default position, even 22 weeks and above. Whereas if you come to the studies in France and the UK, there is a huge difference in how we approach, how we manage extreme preterm management at limits of viability. And one of the things that obviously comes into this is the fact that we respect parents' choice. And more or less at 23, 24 weeks, I think if parents were very uncomfortable, 23 weeks, I would say, and they wanted not to resuscitate, at least in the UK, we would be completely comfortable offering them that choice and saying we should do nothing. Again, I would say at 22 weeks, that's very much the case. But once you come to 24 weeks in the UK as well, I think if the baby has the kind of survival profile of a baby that is 24, 25 weeks, we'd find it very difficult not to offer resuscitation. But if then something catastrophic happened that made the prognosis worse, the baby got bilateral grade 4 IVH, or was in a situation where this baby has very severe morbidity, then what we would be able to do is offer the parents the choice of stopping life-sustaining intensive care at those gestations. The one problem that is then argued, and this is something that I'm going to ask all of you, is that we offer parents a choice here. When we think the chips are down, that is, the baby's not doing well and has a very high risk of mortality or severe morbidity that will make this baby's quality of life quite poor, or if we don't have a treatment to treat them. So we're offering the parents a choice there, and if they want to stop, then really we would be comfortable doing that. The problem from our perspective is if we then feel that we need to stop and the parents disagree and want to carry on. And one of the major aspects that comes into this clinical picture is the concept of religion, culture, and futile treatment. And when I say futile treatment, I would say that there are certain situations, and I'm giving you extreme prematurity as an example, where we would feel that further treatment is not in the baby's best interests. Now, when I say that, I'm thinking about a baby maybe who has bilateral grade 4 IVH at 23 or 24 weeks. And in that situation, it is almost always associated with a poor, very poor neurological outcome. But again, the risk of mortality with bilateral grade 4 IVH, especially in the acute phase, is quite high. Now, in those situations, if we have a parent who declines, and it is their belief, as it is with certain religions around the world, and I will talk to you about those, then what is your feeling? So as a group, if you have parents who have very strong religious beliefs, how would you approach that in France?
But it's taking into account, but it's not the final decision.
Okay, so the parents say, no, you cannot stop resuscitation. So would you be comfortable then proceeding without the parents being on board?
Well, we have to try and convince them.
Okay, and then not convinced. We've had multiple discussions with them. So how would you approach that situation?
Try and convince them.
Okay. I'm keen to tease that out, because I think when we say try, that's a very broad term. But what have you done in practice? I'm speaking to a very learned group. We have Gilles, Claire. I'm just conscious. What exactly would you be able to do? How would you convince them? What objectively would you be able to say?
Not a life worth living.
Okay, fair. So not a life worth living. Are we certain about that? Are we certain about that? So if I gave you a situation, bilateral grade 4 IVH and a 24-weeker, are we absolutely 100% certain that if this baby were to survive, it would not be a life worth living as a medical team?
No. Yes.
Well, more or less, I would say that the prognostic outcomes are very poor with bilateral grade 4 IVH. So you could agree that the medical team has certainty. But the problem for us is, do the parents believe that is the case? Now, if they were happy to live with a severely disabled child, would you, as a team, would you accept that?
No.
Okay. So let's, how many of you, yeah.
We have yes in the part of the room and no in the other part.
Okay, that's amazing. So I'm really keen to first speak to the people who said no. So why, what is your feeling? Why did you want to say no?
Because we work for the children, not for the parents.
Okay, that's important. So you're absolutely right. The best interests of the baby are at the heart of all the medical care that we're providing. And what we want to make sure is that A, we can treat what we see in front of us, but B, that this baby should have a certain level of quality of life if he were to survive. But I think that the other thing is, we don't want this baby to suffer. And really, a lot of extremely preterm babies, if you take them through their journey, they have a lot of suffering. If you look at the number of procedures we do, the number of times we sample these babies, a lot of extreme preterm babies will end up having problems, surgical problems needing operative intervention, very high risk of CP, and needing treatment for developmental delay and motor problems, sometimes severe enough to be in a wheelchair. And really, I think that's the kind of outcome that we worry about in situations like this. And for that reason, what we try to do is we try to get parents on board. So now what we're going to do is we're going to have a little bit of a case that I'm going to present you. So first of all, this is a real case, and I'm going to give you a little bit of a flavor of exactly what problems we faced as a team. But then after that, what we're going to discuss is really why and how we might approach parents where we have ethical decision-making dilemmas or disagreement. So this baby was delivered at about 23 weeks of gestation, and actually from our perspective had very severe respiratory distress syndrome. Now, at 23 weeks, I would say that our institution is relatively, I would say, aggressive in management. And during the early phase, I mean, this baby had 2 doses of surfactant, had very, very bad chorea amnionitis, so had antibiotics for a decent period, was oscillated and had nitric oxide. Now, in the 4th week of life, the baby had still not extubated. And actually, the baby had a large PDA, and we tried medical management in the first 2 weeks, but that failed. So the baby had a PDA ligation with a view to seeing if we can actually help with this baby's lung disease. Now, after all of this, we were able to extubate the baby for about 3 weeks at 5 weeks of age. And the baby in the 2nd month actually went up on feeds, and then got re-intubated. And this was secondary to an episode of infection. So the baby was treated for infection, and we then decided at about 8 weeks of age that we're going to give the baby a protocol of steroids, a DART protocol, to try and reduce lung inflammation. But unfortunately, the baby did not respond to this DART protocol and remained intubated, very sick. We worked up anything that we could treat. And I mean, the baby didn't have any other risk factors, no cystic fibrosis, no torch group infections, normal thyroid function. But at term, so 17 weeks later, this baby was still intubated and ventilated. And if you can see the X-ray on the right-hand side, you know, for a baby that's nearly term, it's horrible. You have very severe cystic chronic lung disease with significant areas of cystic change. You know, this is a baby who, at this particular point at 40 weeks, was on our Sensimedics oscillator, keeping the lungs recruited, you know, heavily sedated, paralyzed on multiple treatments. An echo showed very severe pulmonary hypertension, so sildenafil was started, but we were in a situation where we were really struggling. So as a medical team, we met with the parents and we spoke to them about a further course of steroids. And you know that multiple courses can affect brain growth. But I think the overall feeling at that particular point was that we try and give this baby another course. We extubated to CPAP, and really the baby didn't last. So in about 12 hours, the baby, despite being extubated to non-invasive ventilation, went on to be reintubated again. And I think from our perspective, you know, once you're kind of in that situation where you've done 2 protocols of DART, you're on maximal anti-pulmonary hypertension kind of treatment. We were treating this baby for reflux. We had problems when we did the head scan with no significant large IVH, but quite severe cerebral atrophy, very wide extraaxial spaces. And if I tell you about feeds, the baby was tolerating feeds, but with a great deal of difficulty. So we were kind of in a situation where I think as a team, we were stuck. So we had discussions with the parents, and between term, 40 weeks and 44 weeks, over 4 kind of weeks, we had multiple discussions, just like you mentioned right at the start. We tried to convince them, we tried to talk to them, but really the parents had a very strong conviction that this baby would survive and that there would be a medical miracle. And that at some point, as long as we believed as the medical team and kept treating the baby would improve and eventually would be able to take the tube out. Now, at 44 weeks, we were in 100% oxygen. We then couldn't saturate the baby, so we restarted nitric oxide. Baby had already had azithromycin. We were on high-dose diuretics, sildenafil. We went back to the parents again, and the first thing that we tried to introduce is the concept of futility, in that we didn't have any further treatment options. So parents came back to us and said that actually we strongly believe in God, and God will cure our baby. So how would you approach that now as a team? You've got the history. Do you have any questions about the case?
Did you do any neurological evaluation?
So in terms of neurological assessments, what I'd say is that we scanned the head, which showed quite significant cerebral atrophy. But because the baby was on quite a bit of sedation, often paralyzed, doing a neurological assessment to see whether there's existing neurological kind of deficit was difficult. But certainly the head scan didn't show major IVH, and there wasn't any evidence of PV, periventricular leukomalacia, or cystic change on the head. So the head, other than atrophy, was in that situation. The bowel was functioning. We obviously, from a cardiovascular perspective, were not on inotropes, but at 44 weeks, this baby was about coming to 4 kilos now and really struggling. So anything that you'd like to ask? Any other questions? Anybody else? Anything? Okay, we'll move on. So how do we approach the situation?
Somebody wants to know the education level of the parents.
That's fantastic. That's absolutely fantastic. So well educated, with a degree. Both parents, one of the parents was a pastor, and that's the father. And the mother was educated, degree level education. She was working as a teacher. A very good understanding of and command of what was happening to their baby. So anything else? Any other questions?
En français, on traduira si vous avez.
Is it their first baby, their firstborn baby?
Amazing. Now, these are beautiful questions. Thank you. No, it wasn't actually. They had 2 other children who were alive and healthy.
Okay.
So,
And
yep,
go
for it.
They're Christians.
Okay, I'm not going to reveal that just yet. Is that okay?
Okay. Okay.
Is that okay? Because we'll talk about religion. Is that relevant?
Maybe.
Okay, that's a good answer. So what I'd say is it might be, and this is really important. I mean, when I give you my framework, I think from our perspective, culture, religion, and spiritual values, they have a very wide range of connotations. So the fact that somebody has very strong religious convictions about the sanctity of life is one aspect. But I can also tell you that there are certain communities where parents might be afraid to make that decision, because actually what they're really worried about is that they'll be ostracized from the community for going against their religious beliefs. So actually, I think if you put yourself in those shoes, it can be very difficult. And what we did in this particular situation was we decided that actually, because we wanted to support the parents at this particular point, we went in for an experimental trial of surfactant at that age. I think at that particular point, we used a concept which we call the best interest principle. And the best interest principle, basically, from our perspective, was to see whether while we're trying this treatment, we can keep the baby comfortable. Now, clearly, by 50 weeks of gestation, what we realized is that there were significant problems. The staff, nurses and doctors looking after the baby was starting to struggle. This baby was starting to have frequent desaturations. There was evidence that this baby was having seizures neurologically. We were having problems with quite significant pain. The baby would grimace. It was developing tachyphylaxis resistance to the sedatives. We had to change sedatives again and again. And if we couldn't, we'd have to keep the baby paralyzed for long periods. But not only that, the baby was also starting to have periods of prolonged hypoxia. So, saturations of 85 to 88 and 100% oxygen. So a very, very difficult situation for us. So we went back to the parents and we asked them and we said, would you consider stopping life-sustaining intensive care because we are worried that your baby is suffering? And again, they declined and said that God will save the baby and that we need to carry on trying to save the baby, doing our best. They felt quite upset. They felt that some of the staff who were working around this baby had given up, and that we weren't giving their baby the right care. So they asked for a second opinion. They said, is it possible for us to move the baby to a hospital where that hospital can look after our baby, because we've lost trust in you. We don't think that you're actually trying to treat the baby. So when I look at the situation we were in, we were accused at one point of not doing enough and letting the baby die. The parents were also quite convinced that at some point, if we continued good care, that a medical miracle would cure the baby. So how do you feel about that as a group?
Oui, le ressenti du groupe.
I think at this point we don't talk the same language. They talk religion and we talk science. And,
okay. Can I ask, who is right? Are they right or are we right?
Very difficult question.
Nobody is wrong.
Okay, but there is one very big problem, that actually there's a baby at the end of this. So what about the baby? Who has the baby's best interests at their heart? Is it the parents or is it us?
The medical staff.
Okay, so the medical staff have the baby's best interest at their heart, because we're educated, we're scientific, we know, we treat, we've seen long-term neurological outcomes being quite poor. So we're right. Is that correct?
Yes.
So what about the parents' beliefs? Are they important?
Yes.
Okay, so how do we reconcile both these things?
I think we have to bring the clergy.
Another member of the cult,
Voilà.
and
To try to explain that maybe
Yeah.
the hand of God is the medical staff.
Okay, that's amazing. That's amazing. So we can assume now that we are trying to get the parents on board. So you can use maybe other people who share their values and culture, maybe from their community, maybe a medical member of the staff has and understands those religious leanings and can speak to them about it and try and get them on board. But I think for us, it was very difficult. So what we had to do is we could not stop intensive care of our own accord. So this is really important. By law, while in the UK, we are allowed to make those decisions, and medical care and the medical team leading care has, I would say, overarching responsibility for the care, but also for the decision-making over the parents. What we can't do is, if we disagree, is agree that we're just going to pull the tube and let the parents not be involved again. We have to do and go through a proper process. Now, that process could have meant going to court, and court would give us an order which would say that you can actually stop life-sustaining intensive care. So how many of you think that we should go to court, and how many of you think that we should try further treatment? I'm just curious. So I can't see all of you, but if with a show of hands, how many people at this stage feel that we should carry on and try something else?
Nobody.
nobody.
Okay, everybody wants to stop?
Yeah.
Okay. Would you, I mean, nobody wants to give a third course of steroids? Do you think we're crazy? So, can I ask, how many people over there think we're a little bit crazy? Feel free. This is something that I really enjoy.
I think that if the baby is suffering, It's a little crazy. It's not in the baby's best interest if he's suffering and you can't manage his pain.
Okay, fair point. So what you're saying to us is that if the baby's suffering, then this is really not in the baby's best interests, and that is key. So if I could keep this baby comfortable by sedating and paralyzing him, so by now he's about 6.8 kilograms. So you can imagine he's a 7-kilo baby who should actually be on PICU. We can't move him because he's too unstable, and the parents will not let us stop. So if I can keep them comfortable, give him enough sedation paralysis, would you be comfortable carrying on as a group? What's your consensus? I want you all to have a think about this. Would you be happy to carry on, or would you like to stop?
Si on arrive à le rendre confortable, alors on continue pas.
C'est toujours notre truc d'acharnement déraisonnable, même si c'est juste pour maintenir la vie.
Vous maintenez le groupe?
Non,
Non, enfin, vous maintenez la position? They maintain the position they had just before.
So they want to stop. So how are you going to do that physically? How are you going to do that? How would you do that in France? How would you approach that? Would you be able to extubate at this point?
No, we have a special law for that, Alok, named Loi Leonetti, and we can't, when it's unreasonable, to give care that with normal drugs at normal dose, but can kill the patient by the end. If it's the best interest of the patient, we can do that. But we can't put off the tube and blockade, muscle blockade, for example. It's forbidden, of course. But we can have an escalation of the sedation.
Okay, amazing. So clearly from our perspective, the ethos is keeping the baby comfortable. And I'm going to skip the next slide very quickly, because from that case, before I tell you what happened, what I'd like to talk to you about is actually the concept of religion. We're going to talk about religion first, then we're going to talk a little bit about cultural values and beliefs. And what I'd like to emphasize is we as a medical team really need to think about what religion means in the context of the current case. And that's where I think as a team, we probably went wrong. So when people talk about religion and they use statements like medical miracles, we know that certain religions believe in medical miracles, but there are other religions who might, from our perspective, espouse different concepts, like a very important concept with certain religions. And I know certainly I'm a Hindu, I'm from India, but I think the sanctity of life, if you look at the Jewish religion and the Hindu religion, is paramount. And I would say that a lot of Roman Catholic colleagues and parents, again, believe strongly in the sanctity of life. So their view is that we do not have the right to play God. We do not have the right to decide whether a baby should live or die. Actually, this the sanctity of life, as prescribed, is paramount and at the forefront of everything. And it's not for either the parents or the medical team to decide that we should be ending life. The second thing that we talked, and this is what we found with this family, is a lot of religions believe in miracles. And again, I can tell you, how many of you have you ever watched a Bollywood movie, an Indian movie?
Yes.
Okay, so for those of you who watched it, I mean, some of you will kind of see that there are all sorts of miracles. You know, the hero basically can lift 2 cars with his bare hands, throw them all over. He can serenade 3 girlfriends at the same time. He can fly 1,000 meters into the air. But more importantly, if he gets killed, he can actually reincarnate, come back in a different life and act in the same movie again. So really, if you look at my religion, I mean, we have miracles and faith in miracles. And really, if we have a strong faith, as long as the baby is alive, you know, some families will say, well, we need to wait for God to produce that miracle. Now, there are also religious scriptures. Now, and I'm not talking about specific religions here, but there are certain religions which basically say that we are not allowed to withhold or withdraw treatment. It is not actually religiously acceptable for us to say that we can, and what I'd say is the Orthodox Jewish religion does not believe in withdrawing treatment. And we're going to talk a little bit about the differences between withholding and withdrawing treatment. The last concept that I would say in religion is certain religions believe that you have to have and be able to demonstrate that the child is brain dead before you can actually stop life-sustaining intensive care. Now, the challenge with that is for a baby this big who's sedated and paralyzed, we can do an EEG and that'll give us some information. We can do stimulation of the ears with water to kind of see whether we've got a vestibular reflex. We can try to look at raising the CO2 to see if the child breathes. But actually, the one issue with that is it does not actually imply that the child is not suffering. The child is suffering. So you might have a child who's not brain dead, but is suffering and treatments aren't available. So it's not in the baby's best interest. But religion says that unless you do and demonstrate brain death by whatever way, you're not allowed to stop. And then this last aspect, I cannot emphasize this enough. There are certain religions where if you allow your child to die, you are going against your religion, you're going against community. And actually in that situation, not only you, but your entire family can be completely ostracized from the community. For that matter, even, given a very hard time. And parents may sometimes put that over what is happening to the baby. And the most important thing from my perspective is, I think you have to respect all of these things. But the reason I'm talking about all of these things is, if you know exactly what the parents' beliefs are, then there are mechanisms which you can use to try and address this, to try and get the parents on board. And I'm going to give you a few examples. But before that, let's look at different religions. So this is a very nice paper that's basically published by Sprung and Bulow in Intensive Care Medicine. And what it basically talks about is the religious beliefs on end-of-life decisions. Now, what I'd say is that there is, as per this paper, and I would say in real life as well, there's a difference between withholding treatment, withdrawing life-sustaining intensive care, and certain other concepts like the doctrine of double effect and euthanasia. Now, if you look at Catholics per se, they feel comfortable with both the concepts of withholding and withdrawing care. They also believe that it's really important that if the baby is suffering, that we try to alleviate the suffering, but they would not allow for euthanasia. Now, I would say that this is a very broad group, because actually there are some Roman Catholic parents, in particular in certain countries like Nigeria, where there is a very strong belief that actually we should not be withholding or withdrawing care, and that miracles do happen. I think if that Protestants, again, it's very much similar, but some Protestants also believe in the concept of euthanasia, which is basically stopping life-sustaining care and allowing the baby to die. If you look at Greek Orthodox, and we spoke about this, for them, they will not permit us to stop treatment or withdraw treatment under any circumstances, nor from our perspective will they allow us to increase sedation. So Gilles talked about your setup where you can increase sedation. So for them, that's unacceptable. The baby has to be kept alive at all costs. Now, just to give you a little bit of a flavor, what about the Hindu and the Muslim religions? So have you had any experience of dealing with Hindu families or Muslim families?
Yes. Yes.
Does anybody want to give me an example of any difficulties that they faced?
So, for example, they never accept pregnancy stuff, or
Okay.
it have a very severe heart disease, for example.
Yeah.
That is not viable or viable with a lot of surgery.
Yeah. So you feel that the parents won't agree because of their religious beliefs?
Yes.
Okay. So this is a very important aspect. So when you look at scriptures and the Quran, actually in the Muslim religion, it does allow, and it does allow for both withholding and withdrawing life-sustaining intensive care. And I would say a lot of families, both in the Hindu and the Muslim religion, are quite comfortable with that concept. Now, I work in the UAE, where we have Islam as the religion, and I just I'm giving you my experience to say that actually we practice palliative care as well as people do in the UK and in France and Sweden, and really the majority of parents where we're able to speak to them and explain that we've reached a point of no return, we're in a situation where further treatment is futile, or where we feel that we're in the situation where we cannot give this baby a good quality of life. When we speak to them and if they come on board, then really from our perspective, withholding and withdrawing treatment are both accepted. Withholding, from my perspective, might mean that actually you have a ceiling of care and you establish that you're not going to go above that. And a simple example is that in our baby that we had, what we agreed from our perspective at one stage was that we would, if the baby had a cardiac arrest, we would not give the baby adrenaline, and the parents were comfortable with that. They also, we agreed that we wouldn't give the baby compressions. What we did agree, however, is that if the baby had reversible things like infection, atelectasis that we would treat those things to try and keep the baby in the best optimum state. So really, what we were able to achieve with a family is withholding or a ceiling. What we couldn't achieve with our baby is the concept of we'll extubate the baby and actually the baby will die. And really, I just wanted to correct any misconceptions people might have in saying that Muslim or Hindu families, often based on religion, will not allow withholding or withdrawing care. That's not what the scriptures actually say. The parents may, however, have strong beliefs. The community may have strong beliefs. And that might mean that the parents then want to stop, not just because of the scriptures, but because of really their convictions and the worry that they'll be ostracized. Now, if you look at the Jewish faith, again, I would say, believes in the sanctity of life. It does allow for establishing ceilings of care where you might not want to progress, but it does not allow for withdrawal of care. Again, most religions believe strongly in trying to alleviate pain, even if it will allow this baby to die. And we call that the doctrine of double effect, in that really what we want to treat is pain, but what we also realize is that the medications and sedatives might have side effects which eventually culminate in the death of the baby. Now, as you can see, all religions, bar the Greek Orthodox Christianity, are quite comfortable with that concept. So our problem at this particular point is, how do we address all of this in the context of a child who might be suffering, a child where there might not be any available treatments, a child where we think the quality or the burden of suffering and quality of life later on outweighs intensive care, because keeping this child well will result in a very, very bad outcome, or potentially a situation where the child might be brain dead. And really what we have to do is we have to address these issues. If you don't address the religious beliefs of the parents or their cultural values, then not only are you disempowering them, but we're highly likely to create a concept of conflict between us and them, which then means that we move further and further apart. Now, if we disagree and the child continues to remain alive, it's the child who's suffering. So how do we approach this? How have I approached this as a clinician? So I've been working as a neonatologist now since 2008. I've been in medicine for about 23 years, and I think for me, actually going to court is probably the most difficult thing that a clinician can do. But it is also something where if we get a court order to stop life-sustaining intensive care, we hugely disempower the parents. We take away the ability for them to make a decision for their child. And it is very hurtful and soul destroying. And what you have to, from my perspective, understand is that it is usually in the UK the last resort. Where I currently practice, we cannot go to court. So if the parents do not want to stop, then we cannot stop. And that basically, from our perspective, means that in the UAE, it's the parents who have primacy for making all medical decisions. We cannot go against their will. Now, how do we approach this? How would you approach just without taking religion into account, an ethical framework for offering the family redirection of care? So in my setup, as in your setup, we speak to the parents. We often might need multiple conversations. And really the approach is to try and get them on board to understanding that treatment might be futile, that treatment might not be available, that the child is suffering, or that the morbidity and mortality risks are so high that actually it's not in the child's best interests or benefits to continue with intensive care. Now, at that stage, if they disagree, often what we will do is we will sit down as a medical team and we will reevaluate. And this is really important because we can get it wrong. And I'm going to give you a simple example of a child who had a medulloblastoma in the UK, where the parents felt that the treatment that was being offered was not in the child's best interests. And they felt that a further treatment should be offered, but the treating oncologist in the team felt that actually that treatment was not in the child's best interests. Now, the parents actually absconded with the child and went to Spain and had their treatment. And this child is alive and healthy. So we can actually get it wrong at times. That child is in school. He's leading a normal life. So what is important is that as the medical team, I think we have a wider overview. Are we right? Are we really getting this right for this baby and the family? But I think if we agree that's the case, then in our setup, what we'd normally do is we would go to another tertiary center of our equivalents who have experience in managing babies like this. And we would ask them to actually give us an opinion and say, well, is there anything else we can do to help this baby, treat this baby, something that we might have missed? Or do you think we've exhausted all treatment options? Are we keeping this baby comfortable? What would you do? And do you think that actually our decision to try and limit or stop life-sustaining intensive care is the right one? Now, how do you avoid conflict? So in our setup, I mean, one of the things that I like to do is often give the parents a choice. So we have about 65 tertiary centers in the UK. And we might say to the parents that actually, these are 4 centers who do exactly what we do. They treat babies. What we'd like to do is take a second opinion from them, giving them all the information, including your choices and what you feel, and asking them that question. But you can choose which one of these 4 we go to. You can even choose that we might go to 2 instead of 1. Or you might say that actually, we don't want this particular institution involved. So that is one way of approaching it. The other thing that we will often do in parallel in situations like that is we might do what is called a best interest test. So a best interest test means that we convene an ethics panel. And I know that in Southampton and even in the Corniche where we work, we convene an ethics panel. And what we do is, and I'm going to show you a slide of how we do it, is we weigh the child's current condition, the treatment options, the current outcome of the child, the risk of long-term outcome, and we weigh those balances. And what we look to see is, would a panel, an independent panel, who've not looked after this child with that history, think like us that actually further treatment or keeping the child alive is not in the baby's best interests? The ethics panel might actually come back and say, well, actually, no, we want you to carry on. We want you to give this baby a little bit more time. We want you to establish futility. Now, this is a very, very important concept, establishing futility. But if all of this fails, then the last recourse that we have in the UK is we can go to court. and we can present the case, we can present all our findings, and get all of this reviewed. And normally the process that we follow in the UK for this is usually getting our legal team involved. We discuss and provide the history, but often what we will do as part of that is we'll go to external review, which kind of means that we would present this to another center and say, do you really think we should be going to court based on this? What do you think? What are your approaches to any other treatment? But eventually, if the parents don't agree, then we would approach court. And how does that work? So normally what happens is all of the history, the clinical course today, the views of the ethics panel, the views of the clinicians are collated into a document, which is then presented to a family court judge. And when we present that to a family court judge, he then decides in the child's interests what is the way forwards. Now, I'm just going to give you an example to say, so I'm going to ask you, when we go to court like this as a group, how many times do you think we're successful?
You mean when the judge pronounced the sentence in favor of the medical team?
So the question I'm asking is, when you look at this as a whole, do you think judges or the legal team, in the majority of cases, I'm going to give you a flavor of cases in the UK, do they tend to side with the medical fraternity or the parents?
I would guess in favor of the medical team.
Very good. Okay. So I would say that in 90% of cases, yes, they tend to come back in favor of the medical team. But the one thing that I want to give you a flavor of is religion. So in the UK, whenever we go to court, because the parents have strong religious beliefs, in virtually every case bar one, which has recently taken place in London and Boston, the parents have actually, unfortunately, lost out. And the court decides that actually it's the medical team that has been right. So if there's disagreement based on the religious beliefs of the child, then actually the parents actually, unfortunately, often lose out. There's only one case that I know of in the literature that's quite recent, where we had a Bangladeshi baby who was brain dead with quite significant stroke, where the court actually agreed and allowed the parents to seek treatment elsewhere. I'm not going to go into the details of that case, but that's very, very interesting. Now, the one question that I want to kind of get with you is, what do you think about religion?
Wow.
So is it fair for parents to have religious beliefs that take precedence over the child's best interests?
Maybe it's not the religion
Quoi?
c'est pas la religion qui emmène la décision. The decision that the parents take, I think it's not really based on the religion.
Very
but
good. Very good.
Themselves.
Yep. Now, my experience of practice, and I have, I think with Gilles and Claire and so many neonatologists in Paris, but I'm just going to give you a flavor of my experience of it, is that having been involved in lots of cases like this, there are some situations where religion is and convictions are there, and in this case, it was very much religious conviction of the parents that a miracle would happen. But in other cases, actually, it might not be the case. And I've been in situations where actually it's nothing to do with religion. It's more to do with the fact that the family feels disempowered. They feel that actually we've taken the sacrosanct kind of, I would say, ability for them to be able to decide about their child. That decision should be a parent's decision. It should not be a doctor's decision. How can somebody decide about my child, that my child should live or die? How fair is that? Now, we may think sometimes, and we may make the false assumption that actually this is their religion keeping them back. Now, if you know that's the case, and really you can assuage them and try and get them on board with the fact that actually we respect those values, and really what we want to do is we want to take them along with us, then actually you can change how they feel about that decision-making process. And one of the things that you might have to do for individual families is actually empower them to make those decisions. And empowering them to make those decisions might mean, well, they may feel that taking an endotracheal tube out is wrong. But actually, this baby may be able to limit ceilings of care, stay intubated. We might be able to give good enough sedation to keep him comfortable until such time as he dies. Now, this is really important because this is the practice where I am at the moment. And it's a very respected practice. So in the UAE where I work, when we achieve this situation, because by religion, we're not allowed to take the tube out. The law over here basically says that you cannot extubate a baby to die knowingly. It does, however, allow us to say that we will not escalate, we will not do further treatment, and that if the baby's heartbeat stops, that actually we may agree not to resuscitate the baby. But what we can't do is take the tube out. And that might mean that if the baby has a severe, overwhelming infection, we agree that we're not going to give antibiotics. And that infection causes the blood pressure to become low, the baby becomes toxic, and eventually the baby dies, but the baby will die on the ventilator. And really what you need to explore as a team is a little bit more about each individual family beyond religion. Now, is this a situation where we're taking away their ability to make that decision, which they feel is sacrosanct? And if you can empower them to say that actually you are making the decision, we want to support you in the process, they might agree. The second aspect is cultural values. Now, cultural values are very, very important. And if we don't address culture and values, then really from our perspective, we are disempowering the parents. And what do culture and values kind of espouse? So when saying is that we are the sole authority. That's our culture. We know the best interests of the child, and we should make those decisions. And that the parents actually should not be making those decisions because it's not fair. That why can you allow parents to make those decisions in that context without actually an understanding of the situation? Is it fair? They have to live with the guilt of making that decision for their whole life. But more importantly, we might feel that actually the parents aren't, medically authorized to make those decisions. We're the medical authority. We should be making those decisions. The third aspect that I believe comes into kind of culture and values is, as I've mentioned, there are some religions that believe that parental autonomy is sacrosanct. And I know for a fact that in the UAE, parental autonomy is sacrosanct. So when it comes to making decisions about the child, we cannot overrule the parents. We have to go with whatever decisions they want. Some parents, you take religion out of it. They, as you've rightly mentioned, this might be an IVF pregnancy after 20 years for a child that's incredibly precious to them. So their decision to protect the child's life becomes paramount at all costs. It's not fair for us to push them. And this is where I would say that what you have to do is differentiate whether religion is really the issue there, or whether there's something else that we need to address in the parents' anxieties about stopping life-sustaining intensive care, through which we can support them to come to the right decision for the baby. Now, I'm going to just give you a few minutes to digest things, but any questions so far? Any questions? Can everybody hear me? Can everybody hear me? Hi, Giles, can you hear me? Okay, no problems. That's fine. I get that. That's really helpful. So just as I'm aware, I'm going to carry on, but I think the very important take-home message that I want to give you, and this is the most important aspect of my presentation today, is that we sometimes as medical teams think that religion is the issue here. And in my experience, often it's not. I would say that a lot of the problems that we face in conflict with families is really about taking away the ability for them to make decisions, which they feel they're entitled to based on their culture and values or their religious beliefs. The second thing about it is really that some parents might feel that actually it's not for us to be able to say that we are the people who should allow their child to live or die. And what we really need to explore is really why that's the case and how do we do that. Now, what I normally do in my practice at this particular point is try to identify really what the family's culture and values are. So I'm really keen to kind of get a feel from that family, why they're disagreeing with me. And I'm not just talking about religion here. I'm trying to find out what it is. I'm trying to get a frame in their mind, kind of say, what is the problem here? So I'm just going to take you back to the case, the previous case. And really, you can see that this family strongly believed in the fact that a miracle would happen. And that was our frame. I think religiously, so just to give you an idea now, I can tell you, this was a Roman Catholic family from Nigeria. The father was a pastor. And his overarching view was that actually the person who had to make a decision about life and death was not them, not us, it was God. And that God would have a miracle. Now, how did we address this? We took it on board. We said, we respect what you're saying. But really what we want to do from our perspective is we're kind of wondering whether we've reached a stage of futility. Now, how do you establish futility while you're having those discussions? Is you look at all the treatment that you're offering, and if the baby's not getting better or the treatment's failing, then actually that builds up. And then you can go back to the parents and say, look, we're trying everything. We're trying in this situation, but it's not working. And that might be one way of getting them on board. It might be that we're able to demonstrate that the child is suffering. He's grimacing. And in this case, the child was seizing, having a lot of problems. Pain relief was becoming a challenge. There was a lot of tachyphylaxis to the sedatives. So by demonstrating these things alongside acknowledging the parents' views, and in this situation, the parents' views were strongly that a miracle would happen. What we were able to demonstrate is that with every treatment, the miracle was not happening. And with the miracle not happening, we're still in the situation where this child is suffering. And we were keen for them to sit with the child, see how the child was, a 7-kilo baby on an oscillator with nitric oxide and steroids. It's a difficult situation to kind of be in. But really, this is a very important aspect of establishing where the problem is. And in our case, it was a miracle. And what we wanted to do is demonstrate to them that the miracles are not happening. They remained, I would say, very much with their beliefs and felt that we have to continue. So what we did is we approached court. Now, in this particular case, when we approached court, we presented everything, including the treatment options. And within 72 hours, the judge came back and said that we can stop life-sustaining intensive care. But what we decided was that we would want the parents to decide on when and how that would take place. Now, the baby eventually extubated and passed away comfortably with the parents, having comfort care in a private room. But what I'd like to do is I would like to now discuss a very important aspect of religion. So when you have different religious contexts, do you think there might be different approaches to how we approach religious disagreement? So do you have any experiences?
Can you hear me now?
Yeah, I can hear you now. I can hear you, Giles. So I'm just curious, like if you had a Muslim family, and I would say that while I'm a Hindu, my mother is a Muslim. So just if you have a Muslim family, how would you approach them?
As doctors in France, we don't, we try not to speak of religion with parents.
Okay, but
From my
they have,
experience.
yeah, amazing. Okay, that's fine. That's a fair point. So, I mean, if the parents then feel disempowered because you're not acknowledging their religious beliefs, do we think that's fair?
Well,
I'm
I don't
just
have
curious. It
I
could
have
be
enough-
fair.
I don't have enough knowledge in the different religions to speak about them.
Okay, that's amazing. So, we're going to talk a little bit about it, but what I'd say to you is that at this particular point, what is important from us to kind of acknowledge is that they have a certain view, which might be a religious view. And I think when you sit down with parents, respect to kind of acknowledge and say, you know, what we don't understand, but actually we want to support you, and we can understand why you're saying what you're saying based on your culture and values. I think that acknowledgement, it's across the board. I'd say irrespective of religion, if you can espouse that when you're speaking to parents, that's one way of trying to reassure them that actually you respect those views, but clearly there is a conflict between those views and the child's best interests. And really that's where you're coming in from. Now, one thing that I have learned over years is with families like this, involving maybe a medical member of your staff who is of the same religion or culture and values, to speak to them, to be able to talk to them and reassure them that actually based on the laws of the land, this is perfectly legitimate and actually is something that will actually help because the child is suffering, can really help them. Now, how do we do that in the UAE? So in the UAE, what normally happens is that I would probably get a colleague of mine who might say, for example, have a better, and I have colleagues who are English, I have colleagues who are Indian, I have colleagues who are from Pakistan, I have colleagues who are from Nigeria, you know, I have colleagues who are from the Philippines. So if I have a family like that with a certain religious, cultural background, I might actually ask them to speak to the family because the family might be closer to them and they might be able to use the same language. They might be able to speak to them in a language that they can understand. So irrespective of religion, that's an approach that we often take. But the other aspect to it is there are often members of staff with whom the family may have better rapport. So again, getting them to speak to the family about these issues to try and alleviate their cultural beliefs. But one of the aspects that might be the case, and this is the case that I find a lot in the UK, is that a lot of Muslim families are very worried about being ostracized. Okay. We know that the religious scriptures actually say we can, but actually the community says no. Now, what you might be able to do is speak to their community on their behalf and speak to a community elder or a leader and kind of say, look, this is the situation. Actually, there is no chance for the baby. Treatment's futile, the baby's suffering, but this is what the family is worried about. And really what we need to know from you is, would you be able to support the family if that was the case? And we have done that. And I'm giving you one example of a Kurdish family where they were from Kurdistan. Their religion basically says you can't stop. But we got one of their religious leaders to come and visit and see the child and explain things. And actually, at the end of the day, I think the agreement all round was the parents also wanted to stop. And the religious leader was happy for that to happen. And we came to a very amicable agreement without going to court where we could do all of that and support the family. So again, another approach might be involving somebody from their community, somebody who can speak to them. I also know that can sometimes create problems because you might have community leaders who are very strong with their convictions and say, no, you can't do that. And I'd say that my experience of having done it is I've never been in that situation where a religious leader has said, no, you can't do that. Maybe some others have. Have you ever been in that situation? Anybody ever been in that situation?
No, I think it's very rare to have the cult leader of cult come in the hospital here. Here in France, we have a religious representative but they work with the hospital, and we make them come when we have difficulties with a family.
Okay, that's a fair point. Now, how do we address culture? Now, this is the third thing that I want to talk to you about. We've talked about how we might approach religious disagreement, how we might want to use somebody who's culturally close to the family in a hospital, how we might want to approach religious kind of beliefs through the community or through a religious elder. But I think eventually the crux of the matter is the parental values and what their understanding is of why they want to continue. And what I'd say is the way you speak to them and how you counsel them is crucial. I think going into any conversations like this where we say, well, actually, we're the medical team, we're right, and we need to stop. Well, in my experience, it doesn't work. It really disempowers the parents. And often what you end up doing is pushing yourselves further apart from the parents and creating conflict. There is a concept. Now, the concept that the medical team is always right, and I'm just putting my marker on so that you can see, is called medical paternalism. And the risk of being medically paternal and saying that we are the people with the knowledge and expertise, and we do not want to put the burden of decision making on you for the fear of making you feel guilty, or that we've explained it and you don't understand, so we will be the sole authority making the decision, I would say will not work with a lot of parents. On the other hand, when you have complete parental autonomy, the risk there is that you might continue treatment for a long period while the child is suffering. So is there a middle ground? Now, a middle ground basically says that what we would do in these situations is try and understand why the parents' beliefs are that way and try and find a solution for that. And the solution, like I said, we've discussed two solutions, which is maybe a member of the staff that has those values, maybe religious elders. But a third aspect of it is really trying to reassure the parents that their beliefs are very much respected. And really what we want to do is support them through the process and reassure them in a lot of religions that actually what they're saying and doing is very much legal. And that comes back to this document, which basically says that Protestants, it is perfectly legal to withhold and withdraw and stop life-sustaining intensive care. We want to keep them comfortable. But I think for maybe somebody who might be from the Jewish faith, we might agree that actually we have not to escalate care and we treat the baby until such time as the baby develops situations where he'll eventually die. Now, those babies will often spend large amounts of time on the ventilator. Now, in my setup in the UAE, what we'd do legally is 3 consultants would agree that this is the path to take, that we want to stop or limit life-sustaining intensive care. We'd speak to the parents, and if they disagreed, then we would not be able to stop. What we might be able to do is, again, speak to a member of a different hospital with similar leanings, take a second opinion. But at the end of the day, if the parents wanted to carry on, we would have to respect that wish and we would have to stop. And in my view, the question then becomes how comfortable you can keep the baby, how you manage the baby's pain to keep him comfortable until such time as either we get the parents on board or the baby has an event that eventually means that the baby dies. I think what I'm trying to kind of espouse is this concept of beneficial medical paternalism. So I think if you find that parents can't come to a decision because they feel guilty, what you have to reassure them is that you're making that decision on their behalf, but by taking their religious culture and values on board, would they be happy with that? And some parents would say, absolutely. And I'm giving you another example. So we've had a Hindu family where we had a baby with severe HIE, and that baby basically had grade 3 HIE. We had 3 attempts of trying to extubate. Parents felt that actually the religion says that they can't stop. So I sat down with them because I'm a Hindu and I know that we can. And I asked them, well, how do we approach this? You know, what are you worried about? And they basically said that, look, actually, what we want to know is we religiously are not allowed to make that decision. But actually, if you made that decision for us because you're making it for the baby, then actually we will not say no. Just don't ask us to say yes. So the simple agreement in principle with that family who had a Hindu background was that actually they would not stop us from stopping life-sustaining intensive care. They were happy for us to do that, but what we must not do is ask them to make that decision, because religion says that they're not allowed to make that decision. They're not allowed to make decisions of death, of stopping care. And we extubated that baby, and that baby had comfort care with the parents, and the parents were completely comfortable with that because we made that decision. And we call that beneficial medical paternalism. So what I'm trying to espouse is that if you take and try to explore why the parents feel based on their religion that they don't want to stop, or their cultural and values, you can identify things that you might be able to do where you can then move forwards without actually having conflict. Any questions about this? Okay, I'm going to move forwards. Now, the one thing that I would say doesn't work is going in with absolutism on both sides. And what that generally means from our perspective is that we are the absolute authority. We will take the decision-making away from the parents. That will, in my experience, always leads to conflict and makes things much worse. But I think we also have to be very careful, certainly in the UK, and I believe that is the case in France, of allowing the parents complete parental autonomy in terms of trying to influence care to a point where we think it might harm the baby. And an important example that I'd like to give you is that the parents might agree that we can't stop life-sustaining intensive care because they have strong religious convictions, but they might want us to give something to the child based on their religious views that we think might harm the child. So I think absolutes of either side are not good. And the key take-home message that I would give you, if you have problems with either religious disagreement with families or disagreement based on the culture and value of families, is understanding why. It's understanding why, because it might not be about their religion or the scriptures. It might be because they can't make that decision because they feel guilty. It might be because they can't make that decision because religion says that, but they're comfortable with you making that decision. It might be that they feel the worry about being ostracized in their community, and you might be able to address that through community elders. Or it might be that really religion is the issue, and actually they believe in medical miracles. And one way of getting around that is demonstrating that actually with further treatments, you're reaching a point where the medical miracle is not happening. At the end of it, if we disagree, then really from our perspective, what we try to do is support the parents while we're going through this disagreement. And really, the one aspect that I would like to address with you is a lot of staff in this situation have what we call as moral fatigue and moral distress. So eventually they feel that the baby is not being looked after because of the parental views in the best possible way, that the baby is suffering. And we start, and some teams will certainly, when they struggle, when they have moral distress and difficulties, you're not able to produce your best for the baby. And some treatments may sometimes be halfway. Now, for me, that's a very controversial area. I think what I would say is that in situations like this, our paramount driving or driver would be the best interests of the child. In this situation, if you reach the situation, it's the comfort of the child. And I would like to keep the child as comfortable as possible while trying to optimize medical care as much as I possibly can. But the one thing that I would caution all of you about is the concept of halfway house. Halfway house kind of means, well, the parents are not in agreement. We're not stopping, but actually what we're going to do is not speak to them and maybe not do certain treatments. And I think that's an area that is quite controversial. I think what you should do in those situations is try to agree, withholding rather than withdrawing, where the parents agree to having certain ceiling or limits on what you're going to do. And that might mean that you don't give compressions or adrenaline if the baby arrests, or you might say that actually we're not going to give antibiotics if the baby develops a major infection. I think the overall view is what we're trying to do in this particular process is try and get the parents on board. So how do I summarize this framework? So at the end of the day, if the parents disagree with us and there's refusal on religious grounds, what we should really be doing is trying to understand what this refusal really means. Is it actual religion, or is there something else? And can we help alleviate that, excuse me, to allow decision making? Now, the one thing that you can do is you can have medical mediation, and we have a lot of, I would say, colleagues in the UK who now help to mediate between parents and doctors. Helps again address and prevent the parents from being disempowered. If everything fails, then really a second opinion, the ethics panel, progressing to legal review. And again, what I'd say to you is that if we've been to court in the UK at least and fought on religious grounds because the parents have strong religious beliefs that we need to stop life-sustaining intensive care, bar one case, the court has always come up in favor of the medical team. So to summarize, I mean, in this situation, we had parents who had very strong Christian beliefs, but we presented the case to the court, and the court basically gave us an order to stop life-sustaining intensive care, and it took 72 hours. We got the parents on board, but really what we did is follow this process. And I think if you tend to stick to this process and understand the frame of how the parents basically, or why they're refusing, and you can assuage their concerns, you will get it right. What is the best interest principle? Now, this is an important slide. So really, what we're trying to determine is whether, when we've reached a point where the child is suffering, is whether to continue intensive care or whether to stop. And these are the things that balance stopping intensive care. So if the child is suffering, now when I say suffering, suffering needs to be objective. So just because the child has a heart rate of 170 with no other signs does not indicate suffering. Suffering should be objectively defined. I think if you're certain that survival is unlikely, so simple examples are lethal abnormalities, anencephaly, or a lethal kind of mitochondrial disorder. Now, in these situations, we know for a fact that survival, based on literature and evidence, is unlikely. If in that situation we're stuck, we get a second opinion, maybe a third opinion, and everybody agrees that it's likely. And or if we don't have any treatment options, it's futile, then actually these, obviously from our perspective, outweigh some of these aspects. And in that situation, that's how the medical team then decides that actually we should stop medical intensive care. What we have to do is get the parents to first understand this. And then if they disagree, is explore, based on the religious or cultural values or beliefs, why, and try and address that why. And if you can address that why, my experience is that you will rarely ever go to court. I've only ever been to court once in 14 years of having done neonates. And really what I'd say is the majority of other cases, including where I work in the UAE at the moment, we're able to get the patients on board. So that, from my perspective, is the end of my talk. Do we have any questions? You can type them. If we can't hear you, you can type them in the chat box. So what I will be able to do is I have recorded this session. So for those of you who missed it, I will send this in a WeTransfer link to Gilles so that you can watch it again. But I have a feeling that we're not able to chat. I can't hear Gilles. Gilles, are you there?
It's again okay with the microphone, I think.
Yeah, I can hear you now.
Yeah, Caroline?
Yeah, I had a question. So where you work now, it's always the parents who have the last word?
That's correct.
Always.
Always.
And-
Mandatory by law. That's law.
Whoa, so you have been in situations like very complicated where you couldn't do anything for
That's correct. So I have a child at the moment who is coming to 11 months of age, who's still intubated, ventilated with what we think is end-stage chronic lung disease. And I'm a neonatologist. I have to look after him as best as I can. So yes, there are situations where once the parents have decided we cannot overrule those things. What I'd like to reassure you about is the majority of cases we are, and in situations like this where we aren't, like I said, the most important aspect is keeping the child comfortable and making sure that we're optimizing treatment to a point where we're giving the child the best possible chance of being comfortable as well as a good outcome if he survives. There are huge challenges.
Please, can you allow the participant to come in?
Yep, I've let him in. Yeah.
Yeah, you can see us now because it was very sad. You can see the room. And Claire is not there. She's just beside us with the ethical discussion for patient.
Yep, amazing. Hello to everybody. It's so nice to see all of you. God bless you all.
Thank you.
Thanks so much.
I have a question, please.
Yep.
Do you have some case of abuse in the law there in the UAE?
So, how would you mean? Just so
There in the law, something about abuse the child. In the case that if the parents refuse to stop the care, can you consider it like an abusive situation or not?
So that's a very, very nice question. So what I'd say is that I can give you my experience, and I'm coming to 2 years over here, is that I've never been in the situation where I felt that continuing treatment, because the parents want me to do it, is abusive of the child's rights. The reason for that is my focus as a clinician, if that's the case now, is about keeping the child comfortable. And really in those situations, my experience of parents over here is they often won't question medical care in those situations. They will want us to try our best. They will want us to keep going. But my experience is that they really believe and they want their child. I've never been in a situation where if I've come back to them and said that actually I'm worried we're not sedating the child enough, I'm worried that actually we should not be putting a line in, actually I can manage, I don't want to do a lot of invasive procedures. Experience often says they're on board with that. What they might not be on board with is the fact that we take the tube out without their permission. What they might agree is that in this process, if the child dies with the tube, then actually neither they nor us have made that decision. God has made that decision. So if you get what I mean, I'm not really, convinced that I feel that the child is being abused in that situation just because we're keeping the child alive. If you get what I mean.
And how hard is it for the parents to have the whole responsibility of the limitations?
That's a very good question. That's a fantastic question. Now, this is a question that I'm asked a lot by my colleagues in the UK. Now, the one thing I would like to say to you is what we need to do as clinicians, as medics, as nurses, is explore. Sorry, I'm echoing.
C'est moi qui fais du larcène.
You might have to mute one of I think Claude might have to mute his phone.
Non, je pense que c'est Gilles. Okay. C'est Gilles qui perturbe.
Oh, that's okay.
Ça y est, j'ai coupé le son.
Ah, c'est bon? Okay.
Okay, so what I'd say is that in situations like this, the approach I like to take, if I'm in the situation where we feel that is the case, so could you just repeat the question? I've just had a slide block. Sorry.
In France, it's the medical team that has the last words. And so often we say to the parents that they don't have the responsibility of the limitation of their child. Whereas in where you work now, it's the parents who decide if their child lives or dies.
So the way I'd approach a conversation like that is I would want to get the parents' frame of mind. And really what I would try to do is reassure them that actually this is the right thing for their baby for these objective reasons. Now, if they still disagree, further conversations involves getting them on board. I think going and saying to them that they don't have that right, even if it's legally the case, will sit very badly with those parents. And the question is, how do I take the conversation forward to get them on board? And experience says that in the majority of cases, 9 out of 10 cases, we've more or less been successful. It's the odd case where we become and have problems with these irreconcilable differences. But I think if we go and tell them that they don't have the choice or the right, then that is absolute paternalism. And in my experience, that hugely disempowers and leaves the parents with a lot of trauma and a lot of guilt that they couldn't do what was right for their child because we made that decision. So coming back to the question before this about whether parents feel guilt and whether we should take that guilt away because we're the medical authority, is I would say try to individualize this to every family. So I will sometimes in conversations with families in the UK ask them that actually I have seen parents who feel very uncomfortable about making a decision of life and death for their baby. And really, I want to take that burden away from you. But actually, I've also seen families who want to be involved and want to make those medical decisions. And if that's the case, can we do this together? Can we see what you feel about it? So it's really exploring for each individual family what that decision-making process involves. And I think if you approach it that way, as opposed to the parents are the sole authority or we're the sole authority, my experience is you'll be more successful. Does that help?
Yes, very much. Thank you.
Any other questions?
Hello, Alok, it's Claire.
Hi.
Hi. Hello, Alok.
Yep. Hi, Claire. One last question? Any last questions?
Yeah, with out of this situation, how long time do you stay in Dubai? Do you come back in Southampton one day or no?
Yeah, I come back every 2 months, and I usually have 3 weeks, so it's a long time. Yeah.
But not to work at the hospital.
No, not to work at the hospital. No, can't keep 2 jobs.
And we have a research project, and we have to discuss that. But I recall, I told you about counseling, and this type of discussion could be discussed.
Absolutely, and I'm really looking forward to it. I think so. Just to give you a flavor of, we're doing a research study on ethical management of babies. So I'll share that with Jules to show you. But really what we're doing is we're asking obstetricians and neonatologists in the UAE how they feel, what are the reasons they feel we should be stopping life-sustaining intensive care, and how they feel we should be doing it. And it's an interesting study. We're looking for about 170 sample size. Hopefully, maybe in about a year, we're running May 1st to May 1st. When I present next year, I'll be able to share that with you.
Okay.
Thank you so much, everybody. I'm really grateful, and I hope I didn't bore you, but God bless you all. And I hope you have a good day. Thank you.
Many thanks for your help.
Thank you very much.
Bye.
Bye-bye.
Thank you. Bye.